Hey, everybody. I want to call this meeting of the House Health Committee to order. I just want to note that we're going to have, there's a lot going on this morning, so we'll have members coming in and out, and some votes by designation. So, but Devin, will you please call the roll?
Chair Frankel.
Here.
Representative Benham.
Vote by designation. Oh, she's, yeah.
Still designation. Representative Borowski.
Designation.
Boyd. Here. Fiedler.
Here.
Khan.
Here.
Kozarowski.
Designation.
Krajewski.
Here.
Mays.
Designation.
McAndrew.
Designation.
Freelatin. Here. Sanchez.
Here.
Schusterman.
Designation.
Venkat.
Here.
Charat.
Here.
Representative Bonner.
Designation.
Gorwitz.
Designation.
Brown.
Designation.
Kiefer.
Designation.
Rossi. Here. Rowe.
Here.
Schemmel.
Here.
Stair.
Here.
Twardzik.
Designation.
Zimmerman.
Leave.
Movecorn.
Thank you. We have a quorum. The first matter on the agenda is House Bill 2363. Is there a motion to consider House Bill 2363? Representative Khan moves. Second, Representative Stair. Okay, who's going to, Mike's going to, you're going to explain the bill, Mike? Thanks.
Thank you, Mr. Chairman. House Bill 2363, introduced by Representative Cutler, will amend the Cancer Drug Repository Program, Act 14 of 2008. It will expand the program to include all prescription drugs but not controlled substances. Individuals, healthcare facilities, hospitals, and health clinics will be authorized to return to an approved participating pharmacy an unused prescription drug that meets the requirements of the current law. Participation in the program will be voluntary. For pharmacies, they must follow all applicable state and federal laws, including laws related to storage, distribution, and dispensing of prescription drugs prior to dispensing them, as is required under current law. The State Board of Pharmacy will be required to report annually on the progress in implementing and administering the Act, including statistics relating to participating pharmacies. The board will also be required to post on its publicly accessible internet website the name, address, and phone number of each participating pharmacy and update the list within 30 days of a change. Thank you, Mr. Chairman.
Thank you, Mr. Siggett. I'm sponsoring Amendment A04851 to House Bill 2363, which is agreed to by the prime sponsor. And Dylan, would you please explain the amendment?
Amendment A04851 allows drug manufacturers and wholesalers to donate drugs to the program. In addition, it maintains the existing practice that prescriptions paid for by medical assistants can be donated. Lastly, it ensures compliance with federal and state law.
Thank you. Is there a motion to consider Amendment A04851? Representative Venkat moves. Representative Sanchez seconds. Are there any negative votes on Amendment A04851? See none. The amendment passes. Leader Cutler, would you like to explain the bill or discuss the bill?
Thank you, Chairman Frankel. Thank you, Chairwoman Rapp. Certainly appreciate your bringing this bill up and want to appreciate the members here. Happy to answer any questions that you might have. And I appreciate the work that the staff did on the amendment. I know that there was a lot of discussion going back and forth, and just want to recognize them for their efforts. As was previously mentioned, the Drug Repository Program started in 2008 with Act 14. It was passed with the best of intentions that would allow Pennsylvania healthcare facilities, hospitals, physicians' offices to donate unused cancer drugs to pharmacies in an effort to aid those low-income patients in getting access to life-saving medications. And I first introduced this underlying bill in 2018 when I had a constituent come forward, Mr. Hess, whose wife had just passed away, and he ultimately had to throw away tens of thousands of dollars worth of cancer and non-cancer medications, and he kind of raised the issue with me at that time. Upon doing some further research, we learned that there really are only 2 programs that currently are using the existing program as it is written. So through that research and through these efforts, we wanted to try to open up the program both in terms of participation as well as available donors. And the amendment, while it changed the legislation, it actually changed it to be more in line with the intent of the original bill. It enhances the ability to donate medications, increases the ability of the patients to participate, and expands the kinds of medications that ultimately could be donated and in fact received. I think increasing participation on the availability of life-saving or maintenance medications is good for Pennsylvanians. I think it will ultimately lower healthcare costs, and I think it's already in line with what many other states are already doing. Depending on what you look at, we're one of 6 states that has more of a direct model. 44 states have some form of donation that's allowed by law. And many of those states have reported successful implementation. Unfortunately, our current model remains languishing with inactivity and some challenges. Many patients, in fact, are not even aware of it, and that leads to its underuse. I know that we've discussed my own family history with neurological diseases and some of the complicated diagnoses and treatments and now new medications that are there. But this is a disease agnostic bill and that it would help all Pennsylvanians who have high medication costs. And I've unfortunately saw Mr. Hess be turned away, and that medication ultimately had to be destroyed and was unable to help anybody. So I think it's time for Pennsylvania to update its laws, rejuvenate this well-intended program that is currently being underutilized, and let's ensure a robust system of donated prescription medication exists for everyone who needs these kinds of life-saving medications. I think this legislation and the amendment that was just passed gets us there, and I would certainly appreciate your affirmative vote and happy to answer any questions if there are any.
Thank you, Leader Cutler. Any discussion? All right. Madam Chair?
Thank you, Mr. Chairman. Just want to say to the members that I wholeheartedly support the bill, and the prime sponsor did an excellent job in describing this piece of legislation, so I would encourage members to support the bill. Thank you, Leader Cutler, for being here.
Thank you, Madam Chair.
Thank you, and let me join my colleague in asking our members to support this important legislation. So with that, I'm going to ask if there are any negative votes on House Bill 2363 as it is amended. See none, we report the bill unanimously from our committee. Thank you.
Thank you,
Thanks,
Mr.
Lisa.
Chairman. Thank you, members.
The next piece of legislation we have in front of us today is House Bill 1993. Is there a motion to consider House Bill 1993? Moved by Free-Lawton, Representative Free-Lawton, seconded by Representative McAndrew. Erica, can you please explain the bill?
House Bill 1993 creates new oversight of pharmacy benefit manager contracts with pharmacies to protect pharmacies, including preventing minor typographical errors from resulting in pharmacies being forced to pay back for drugs that have already been dispensed to patients. It stops pharmacies from being forced into disadvantageous terms for contracts and blocks retroactive recoupment of payment and requires any additional PBM charges to be made clear up front. Spread pricing is prohibited, as are closed pharmacy networks. PBMs must accept any pharmacy that wants to join a network within 30 days. PBMs cannot use cost sharing to nudge patients towards specific pharmacies. The requirements on the department include the department must start a new program to oversee disputes between PBMs and pharmacies, creating a complaint, hearing, and resolution process. The Department of Insurance is required to set PBM prices and to create its own state rate comparable to the federal national average drug acquisition cost. And finally, the state employee health plan must pay the highest amount for drug dispensing in the state and must use the state rate for average acquisition cost.
Thank you, Erica. Representative Benham will be offering Amendment A04888. this amendment adjusts the bill from solely relating to support of community pharmacists to providing increased protections for consumers and increased transparency and oversight. Is there a motion to adopt the amendment? Representative Venkat moves. It's seconded by Representative Fiedler. Erica, would you explain the amendment?
The amendment includes the following. Many of the same contractual limitations from the original bill exist to protect independent pharmacies, including pharmacies can't be forced to return their payment for a drug they've already dispensed for an accidental minor error. The PBMs can't go back and retroactively take back payments unless both parties agree it's appropriate to do so. Pharmacies can't be forced into contracts based on certain rates, whether that's a flat discount rate off the list price, say 30% for all drugs, or the national drug acquisition cost, as determined by the federal government. Finally, all other PBM fees have to be disclosed at the time of payment, not afterwards. The bill, as amended, includes substantial consumer protections as well, including blocking PBMs from charging a patient's insurance more for a medication than they pay for the drug and pocketing the difference, spread pricing, prohibitions on forcing patients to use mail order or affiliated pharmacies and allowing them to use any pharmacy with the same contracts with the same cost sharing, protecting patients from paying more in cost sharing than they would buying the medication without using their insurance, creating a robust pharmacy network so that the majority of members in urban, suburban, and rural areas have pharmacies within set distances. Additionally, it creates transparency requirements. Pharmacy benefit managers must report on rebates for all plans and insurers, including the high, median, and low rebate percentages. This information, without specific drug or insurance plan details, will be made available to the public, and the department has the ability to enforce these provisions. Finally, the amendment removes the requirement for the department to adjudicate PBM disputes, takes out requirements that PBMs are required to contract with all pharmacies regardless of cost, and removes requirements related to the state employee health plan. It also makes it clear that the PBM oversight does not apply to self-insured plans.
Thank you. Is there discussion on the amendment? Madam Chair.
Thank you, Mr. Chairman. It's my understanding that this is an agreed-to amendment with both prime sponsors, but I will have more comments, Mr. Chairman, on the bill itself, but I'm asking my colleagues to support the amendment. Thank you.
Thank you, Madam Chair. I as well would like a yes vote from our members. Are there any negative votes on the amendment? Where's the number? What's the amendment number? A04888. See none, Amendment A04888 is adopted and to the bill. We'll have some discussion. Is Representative Benham on online? And Representative Gatos, the two prime sponsors. Would you like to discuss your bill?
Absolutely. Thank you, Chair. Can everyone hear me okay? Yes. So I apologize for joining you virtually as opposed to in person. I am currently recovering from the flu and have to express a lot of gratitude to my local independent pharmacy, Spartan, for making sure that I had the medications that I needed as quickly as they could possibly get them to me. Very, very grateful for that. Also grateful to both chairs of the committee for their work and interest in this legislation, and to Rep. Gatos as well for her partnership. And also Rep. Diorsi worked on some aspects of the amendment with us as well. And so I want to express some gratitude there, a true bipartisan effort. I've been spending a lot of time traveling around the Commonwealth to districts in all parts of the state, rural areas, small towns, suburban areas, big cities. And what I hear from the community pharmacies in all of these areas is like the same song, but a slightly different verse. They talk about the ways in which problems with reimbursements are impacting their ability to stay open, and a desire not to eliminate PBMs, but to make sure that the system is fair. I think it's really important I always tell folks, look, I'm not going to tell you where you can or should get your prescriptions filled. I just want to make sure that we level the playing field, that folks can have access with the pharmacists that they trust, and also aren't forced to order by mail unless they want to. And I think that those are really important consumer protections that restore trust in the system and also help us keep more pharmacies open. We've had over 140 pharmacies in Pennsylvania close since January 1st, and we really have to stem the tide on that. So I would ask my colleagues to support House Bill 1993. This is not the final product. There's going to be additional negotiations and discussions with all impacted parties, and I'm looking forward to continuing to visit folks' districts. If you'd like to have me out to chat with your local pharmacy, definitely let me know. And with that, I'll ask for an affirmative vote and hand it over. I think my colleague Rep. Gatos will have some comments.
Thank you, Representative Benham. Representative Gatos.
Thank you, Mr. Chair, and thank you, Representative Benham, for really putting together this bill, which is a culmination of many other pieces of legislation that have attempted to help deal with medication management and the cost of prescription drugs over the last couple of years. So kudos, thank you so much for really putting this together in one bill. As Representative Benham said, I mean, medication management and the cost of prescription drugs is the essential part of good health care. And while pharmacy benefit managers as a third party came about a couple decades ago to try to help reduce the costs of medications, there are some types of practices which we're seeing in some, not all, pharmacy benefit managers that are leading to higher prescription drug costs for patients, not lower. So with this particular bill, which addresses making things more transparent, more accountable, and has more oversight for the cost of prescription drugs, will really bring the free market to bear here to help reduce the cost of medication ultimately for patients. Now, as Representative Benham said, that this is not the final product. We know that not all PBMs are having some of these nefarious practices which lead to higher costs. So we want to make sure that we take all of the good practices that PBMs have brought and keep those while making sure the bad practices are eliminated. And again, transparency, accountability will help make that happen. So thank you, Representative Benham, and thank you to both chairs of the Health Committee for working together to try to make a very good product here, which we'll continue to do. So thank you very much.
Thank you, Representative Gatos. Other comments, questions from members before I turn to the chair? Okay. Chair Rapp.
Thank you, Mr. Chairman. The issues surrounding pharmacy benefit managers or PBMs are complex, and I won't sit here and pretend to have all the answers, nor can I say that this bill will fix all the problems independent pharmacies are facing. The conversation, just to give you a little bit of history about PBM reform, is not new. In 2018, transparency and oversight of PBMs operating in Pennsylvania. And some of the report's recommendations have become law, such as banning pharmacy gag clauses. Two bills that originated in the House Health Committee became law as well. The first bill, which was incorporated in the Human Services Code, authorized the Attorney General to perform audits of subcontracts with PBMs in the Medical Assistance Program. The second bill, which became Act 120 of 2020, increased transparency and oversight of PBM pricing practices within our medical assistance program. While the bill before us will not solve every issue, I believe it is an important step in ensuring that our independent pharmacies stay in business. Since the beginning of this year, as has already been stated, over 140 pharmacies have closed in Pennsylvania, with more likely to close if we do not act. No less than 21 of Pennsylvania's 67 counties already have fewer than 10 pharmacies. Two counties, Forest, which is part of the 65th Legislative District, and Fulton only have 2 each, with Cameron and Sullivan counties having a single pharmacy serving their entire population. I know that there will be a lot of discussions surrounding this bill, including possible floor amendments. There's also a bill in the Senate, but I believe it is important to start that process, and thus I will be supporting moving this bill out of committee and ask for the support of the members. Thank you, Mr. Chairman.
Thank you, Madam Chair. I want to thank Representatives Benham and Gatos for introducing this legislation and working to advance the cause of community pharmacies and PBM oversight. If I had a quarter for every time I've been told that pharmaceutical prices aren't actually the real prices because of PBM rebates and how we can't ever really expect to understand how much drugs cost, I'd be able to pay for everyone's parking in those old school parking meters maybe forever. The bill we are voting on today eliminates spread pricing, when PBMs pocket those rebate dollars for themselves and get us closer to understand how big those rebates actually are. Additionally, it prevents PBMs from using their own affiliated pharmacies or mail-only pharmacies as a substitute for the hometown brick-and-mortar pharmacies that patients rely on. And it creates a new standard for pharmacy availability for Pennsylvanians. Finally, it tackles head-on the ugly truth that sometimes we pay more in cost sharing when we use our own insurance than if we were simply buying drugs out of pocket. This bill makes sure that we are always offered the lower price for our medication. I know this legislation, as we vote it today, is not the final product, as we've all heard, and that we as legislators must balance access and cost questions. But there is a lot to like in this legislation, and I'm looking forward to voting yes and ask my colleagues to do the same. With no further discussion, I'll ask for a roll call on this one.
Chair Frankel,
Yes.
Representative Benham,
Designation yes.
Borowski,
Designation yes.
Boyd,
Yes.
Fiedler,
Designation yes.
Khan,
Yes.
Kozarowski,
Designation yes.
Krajewski,
Designation yes.
Mays,
Designation yes.
Furlatten,
Designation yes.
Yes.
Oh, she's here. Sorry.
McAndrew,
Yes.
Sanchez,
Yes.
Schusterman,
Designation yes.
Venkat,
Yes.
Chair Rapp,
Yes.
Representative Bonner,
Designation yes.
Borowitz,
Designation yes.
Brown,
Designation yes.
Kiefer,
Yes.
Rossi,
Yes.
Rowe, Schemmel,
Designation yes.
Stair,
Yes.
Twardzik,
Yes.
passes 24-0.
Thank you. House Bill 1993, as amended, is reported unanimously from the House Health Committee. Thank you, members. Next on the agenda is House Bill 2339. Is there a motion to consider House Bill 2339? Representative Furlatten, seconded by Representative McAndrew. Erica, could you please explain the bill?
House Bill 2339 restates federal law and regulation requiring that hospitals make their actual negotiated rates available to the public, including for all price services. This includes the published list rate before any negotiated discounts, each insurance company's rate for that service, the lowest and highest charges of insurance companies, and the discount for people paying without insurance. The formatting must be created to follow federal guidelines and also be easy to use without requiring special logins, passcodes, or special computer programs or instruction booklets to access and understand the data. The list must be updated yearly with the past 2 copies available. Hospitals must also publish 300 shoppable services. Those are the services that patients can schedule in advance and might call around to various hospitals in advance to compare costs. The list must include the 70 required by the Center for Medicare and Medicaid Services, unless those are not provided by the hospital. Once again, the hospital has to publish the same rates: the published list rate, each insurance company's rate, the lowest and highest charges, and the rate for the uninsured who are paying out of pocket. In addition to the federal requirements, hospitals must report on the facility fees they charge. If a hospital is non-compliant, sharing less than 95% of required data, the Department of Health can take action, including fines that increase for each infraction. However, if a hospital receives 3 or more sanctions, it would be barred from receiving tobacco settlement funds and could not collect medical debt from patients. The Department of Health must create a template for laying out the data, and as much as possible, that template should correspond with the template created by CMS for the federal data requirements.
Thank you. Representatives Khan, Kiefer, and Rowe and Sanchez are prime sponsors, and I'd like to offer them the opportunity to make any comments if they so choose. Representative Rowe.
Thank you very much, Mr. Chairman. And I just want to thank Representative Khan for his work on the bill, obviously to the staff, Mr. Chairman, obviously for calling this up. It's one of those niche issues that I've realized in chatting with constituents is actually one of those bigger issues that has maybe kind of flown under the radar. Just some anecdotal experiences. I have a constituent who reached out because she needed a medical procedure and did her homework. She called the hospital, got a verbal review of what the procedure would cost. She made sure she had the out-of-pocket cash available, went, had the procedure. Afterwards, she got a bill for 5 times the amount she was quoted. 5 times the amount. And this is a single mother of 3. She was turned over to collections, and there was no recourse for her. I had another constituent who came to my office and said, hey, I've got 2 bills here from a hospital visit. One is the bill I got at checkout. One is the bill I got in the mail 2 days later for the exact same services on the exact same day, and the second bill was double the first one with no explanation. So that's exactly why I think this bill is really important, and I just want to thank Representative Khan, the chairman, all the co-sponsors. It's great to see that there's some things we can come together on and have consensus on. So thank you, Mr. Chairman. Thank you, Rep. Khan.
Thank you. Representative Kiefer.
Thank you, Mr. Chairman. I, too, want to thank all of the prime sponsors of this. This was a collaborative effort. We need to start somewhere. There is an issue. I, too, have numerous constituents who have come in and have had issues, and one of them, paying out of pocket, has his own private plan, has a very high deductible, so he is very savvy with healthcare costs and tries to determine what it is he wants to pay cash for out of pocket and what he wants to save his health savings account monies for. And similarly, he went in for a series of tests, had an expectation, had called prior to determine what those costs would be, was given a figure, and came out, and it was 3 times the amount, which really hurt his health savings account and him financially where he was going to be. We need transparency. There is a federal guideline. We need to try to align this as much as possible with that. We don't want to burden our hospitals and healthcare systems with additional regulatory compliance. So our intent really is to try to streamline that process so there is one process, but we have to do something. This is not a silver bullet, but it is a great transparency piece, and nothing regarding healthcare prices will get solved until we get this piece done. So I thank you, Mr. Chairman, for running this bill.
Thank you, Madam Representative Kiefer. And Representative Khan.
Thank you, Chair Frankel. Thank you, Chair Rapp. I want to also thank my co-prime sponsors, Representative Rowe, Representative Kiefer, Representative Sanchez, and also the executive directors of the Health Committee, Eric Fricke and Michael Saget. Really, you know, this is a bill that's not a Democratic bill. It's not a Republican bill. It's really a pro-patient bill. It's also a pro-business bill. The reason why I say that is because patients, the average patient in Pennsylvania is already paying $3,500 in out-of-pocket costs a year in health insurance. And that, remember, is before their insurance kicks in. And not everything can you shop around with. You know, if you get hit by a car, the ambulance is going to take you to the ER. You can't choose that. But as Representative Rose said, there are many things where they need to shop around when they're figuring out their rates for their health systems. So this is a bill that makes sense for not only people in the community who are going to be consuming health care, but also for the businesses who are insuring these individuals. Pennsylvania ranks in the bottom tier of the states, the bottom third of states for transparency. Again, as mentioned, this is already law. Hospitals should be following it. We believe that this bill is going to help them to be compliant. We believe that they want to be compliant. And this bill, we believe, is the step to get us there. So, again, I want to thank the bipartisan team that put this bill together and the work that was done by this committee to make this happen. Thank you very much.
Thank you, Representative Khan. Are there other members who would like to speak before I ask the chair? Okay. Madam Chair.
Thank you, Mr. Chairman. First of all, I want to commend all of the prime sponsors of the bill. Bill is an example of both sides, as the prior bill, both sides of the aisle coming together to try to address an important issue. So, as with the prior bill, this issue is complex. This bill will not solve all the concerns surrounding how prices are structured in healthcare, but many of the provisions contained in this bill are duplicative of current federal law. And I normally do not favor duplicative laws. However, I do believe that price transparency is important. Price transparency requirements are intended to enable patients to compare prices and promote competition in the healthcare markets. While well-intended, the federal requirements have thus far fallen short. As too often, there are inconsistencies in data quality, in a lack of clarity on what service prices refer to, and insufficient information to interpret prices. This is the first step, and I'm happy to see that we are moving the process forward in order to continue discussing this issue. I do have some concerns about the bill, and I look forward to continuing to discuss the merits of this bill. I will be reserving my judgment on any floor vote, but I will be supporting moving this bill out of committee. So thank you, Mr. Chairman, and thank you to the sponsors working in a bipartisan fashion on this piece of legislation.
Thank you, Madam Chair. I'm grateful to the many colleagues on the Health Committee, Representatives Khan, Rowe, Kiefer, and Sanchez, who prime sponsored this legislation. I think, as we've heard, it speaks volumes when many members from differing perspectives come together on an issue like this one, and the last one is, quite frankly, as well. It is a truism that the economics of healthcare is complicated. Frankly, I think it's unnecessarily complicated when providers and payers attempt to hide the actual costs for healthcare that we all pay for through insurance premiums, reduced wages, or tax dollars. Federal price transparency efforts started under the Trump administration and continued under the Biden administration. Clearly, price transparency continues to be a bipartisan issue. Unfortunately, while regulators have been explicit about the aims of transparency, compliance has been spotty at best. That's why states have stepped in to make sure that for their residents, the data is available and it is usable. The largest portion of this bill is simply a directive to hospitals to comply with existing law. The additional piece is to make sure any additional facility fees, which get added on when hospitals buy up other offices, get reported. As policymakers on the Health Committee, we are empowered to make policy, but right now we are expected to do so without any information about how much we are paying for what we are buying. Obtaining pricing data will help us make better decisions for all patients in the Commonwealth. With that, Devin, would you please take the roll?
Chair Frankel?
Yes.
Representative Benham?
Designation yes.
Borowski?
Designation yes.
Fiedler?
Designation yes.
Boyd? Sorry. Khan?
Yes.
Kozarowski?
Designation yes.
Krajewski?
Designation yes.
Mays?
Designation yes.
McAndrew?
Yes.
Freeladen?
Designation yes.
Sanchez?
Designation yes.
Schusterman?
Designation yes.
Venkat?
Designation no.
Chair Rapp?
Yes.
Representative Bonner?
Designation no.
Borowitz?
Designation yes.
Brown?
Designation yes.
Kiefer?
Yes.
Rossi?
Yes.
Rowe?
Yes.
Schemmel?
Designation no.
Stair?
Yes.
Twardzik?
No.
Passes 23.
Thank you, Devin. House Bill 2339 is reported affirmatively from the House Health Committee. Finally, today we have a package of non-controversial resolutions to consider that we will be considering as a package. House Resolution 464 from Representative Mahaffey designates July 2024 as MECP2 Duplication Syndrome Awareness Month in Pennsylvania. House Bill 471 from Representative Kinsey designates June 2024 as Scleroderma Awareness Month in Pennsylvania. And lastly, House Resolution 476 from Representative Nelson recognizes June 25th, 2024 as World Vitiligo Day in Pennsylvania. Is there a motion to consider House Resolution 464, 471, and 476? Representative Boyd, second by Representative Stair. Are there any negative votes on these resolutions? See none. They are reported out of committee. And with that concludes the business of the committee today. And I want to thank the members for an efficient consideration of some very complicated legislation today. Thank you.